If you do 4 cases in a day, you're probably going to have a third of those people are going to be either overweight or obese. I did it in my 83. Oh my gosh. I'm sure that was wrong, you know, I mean, you know, it really was. But knowing how to manage these patients and how things are different for you is going to be an important thing to know right up front. So as you're new to clinical, this is going to be real helpful. Just as the geriatric lecture, you're going to see lots and lots of older folks getting their surgeries. I think these 2 lectures are super important because they impact you today, right now. You will get some P's here and there, you'll get some OB here and there before you do like a rotation, and you're going to feel completely like you're not prepared. But I can only do them 1 lecture at a time, basically. And I think these 2 are so important because day 1, you're going to be doing these right up front. All right, so again, objectives are pretty much the same. We want to talk about A&P and patho, pharmacology, anesthesia techniques and procedures, and how do we deal with the complications that come around. All right, this is really depressing. 65% of us, and I don't remember what year this was, but within the last 5 years, are overweight or obese. Okay, that's true. And 30% are obese. That's not just an American problem. It used to be like UK and Germany and US, we were all the fattest people. Especially Mississippi, no offense if you're from there. But now it's a global problem, and it's a huge problem because we expect 300 million people, that to double by 2025. So you're going to be taking care of all of us. I'm going to put myself in that group. And how it affects your anesthetic management is tremendous. Healthy person, when I say that, someone that's a slightly overweight, someone that's overweight or normal BMI to someone that's obese and morbidly obese, just from practical, without looking at any literature, I can tell you, it's going to make your management much more challenging in lots and lots and lots and lots of different ways. Drugs that you give them, how you intubate, how you extubate, the risks go up tremendously, breathing problems. It's just something you just have to get used to and learn how to manage. And you will, in time, you will learn that. And in the meantime, talk with all the people that are ahead of you, a year ahead of you, and the CRNAs you're working with, the anesthesiologists you're working with. They will have tremendous insight. And as prepared as you might be, as far as books, and being prepared in books, when you actually are living it, you're going to be like, I don't know what to do. And then you'll go back to that, oh, I read it. Another problem associated with it is how expensive it is. Just like the fact that the older population is increasing, and we take up so much, a higher percentage of healthcare expenditure. Same thing with obesity. It's getting, the problem's getting bigger and bigger and bigger, and it's costing healthcare more and more and more. So we're going to see these patients. Oh, the issue that you will see, mortality, 4 times greater when someone's obese compared to someone who isn't. Now, if that doesn't scare you, you go, oh, it's only 4 times greater. Would you like to have, what was your last annual salary? Don't say it out loud. Last annual salary, would you like to have 4 times more than that? Okay, I would. Would you like to have 4 times less? 4 times is a lot. And when you think about someone having issues or problems, the risk tremendously increases. So that's why this is important. I may possibly, I don't know for sure, but on your exam, if I give you an ideal body weight calculation, any idea of how to define ideal body weight? Well?
Yeah. It's height and weight, I thought.
Exactly. So if someone is 17, their BMI is 17, we're saying they're underweight. If someone's 25 BMI, we're saying they're overweight. Okay? So how do you calculate it? You take the height in centimeters. I just gave you the little clue. Remember math? All right. 1 inch equals 2.5 centimeters. So you do that in centimeters, minus 100 for men, 105 for women. I don't remember if I have some of those questions on the exam, maybe there. And you know, just basic math, paper, pencil, you know, add, subtract, multiply, divide, you should be able to do that on paper. So how do you get the BMI? It's the weight in kilograms divided by the height in meters squared. Oh, more math. I usually go to little calculators. Done. How do we define it? Different books define it a little bit differently. If you look at NIH, you look at CDC, in some of the books it's a little different, but the basics are the same. So overweight, greater than or equal to 25. If you look at the ideal body weight definition, that makes sense to me. If they're overweight, it's greater than or equal to 30. And then these are the ones that get, they're different depending on what books you look at. Extremely obese, super, super. I don't know, or morbidly obese. If you are greater than 40 BMI, morbidly obese, you're just obese. So the person I took care of was 83. So it must have been super. If you do it in 20 increments, I don't know. Another way to define morbid obesity, more than twice your ideal body weight. That's a quick way to do it. Oh, and everybody probably enlarged this so you could see where you fit on it, right? Okay, who didn't? I know you did. So you should do this before what it was before anesthesia school, now, and then do it a year from now, just to see. If your categories, normal weight would be in this green area, so if you move over here, it's still pretty okay, because you can be able to get rid of that, you know? Now, here's the problem. If I just showed you this, I wouldn't know, whoops, this, man or woman, don't know. What do we call this? Thank you. And if that's being removed, what is that called? It's really fun to say, so you should learn to do it now. Okay. So sometimes when you're doing a procedure, this has to be, if we're doing a cysto case, for example, we may have to move all this up, tape it up. Think about the position of this person on an OR bed. First of all, we have to make sure the bed can maintain that weight. Some of them have a maximum of, 350 pounds. I don't know what this one is, but if it's 500 pounds and the bed max is 350, it's a problem. You put them on the bed goes and crumps. Then they get injured, and they're going to blame you. So, obese person, you have to consider your equipment, and you may have to be using different kinds of equipment. Stretchers are only, this is just like going to the movie theater, right? The chairs are only this wide. Now they're wider. They keep making them bigger and bigger and bigger. There's a reason. Airline, same deal. They used to be this big, now they're this big, but then if they're that big, then they can't have as many seats in a row, so people can be comfortable, or you can have a better airfare price. I don't know. But we're getting bigger, so the world is accommodating for that. In anesthesia, this changes the world. They breathe really well, the best, when they're standing upright or when they're in a prone position. Believe it or not, like when their belly's hanging free. Not prone like when it's mashed, when their body's mashed. But if you're in a prone case and their belly's hanging free, they can breathe pretty well that way. They can breathe pretty well upright and in a sitting position. Oh, but imagine if you're laying supine and all this is kind of pushed forward. What is it pushing forward on? The diaphragm, your lungs. You're going to have a much more challenging time to ventilate that patient. Now, what I typically do is I get when my patient is in pre-op, they're sitting upright, or at least semi-Fowler's position, if not Fowler's position. I get them back in the OR, I'm going to move them over, and they see that it's a flat bed. They're immediately kind of freaking out, because they know they can't lay flat and still breathe. Well, they know this. They live it. So I will let them know, we're going to put the stretcher down for just a moment, have you move over, and in that amount of time, moving over that 30 seconds, they desat, and they get red in the face, and they're huffing and puffing to move their own body from the stretcher to the bed. As soon as I get them over, I immediately put them in a reverse Trendelenburg, pulling the weight back down, I put the back up a little bit on the bed, so they're in as comfortable as a position I can get them in. And then I raise the bed to my intubating height. So one thing that works pretty well to help is to get that person over, because it's flat stretcher to flat bed, get them over, put them in reverse Trendelenburg, and then put the back up a little bit. And that helps. You're going to have to denitrogenate them a little bit longer probably, because they're going to tend to desat much faster. So you may have to take a little bit longer up front. Of course, you have some of the surgeons standing there going, let's go, let's go, let's go. You have your urologist going, hey, 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 let's go, let's go, let's go. And you're like, I'm going to wait until the saturation gets up to whatever, 97, 96, above 88, above 75, okay? You know, I mean, yeah, you're laughing, but it's true. You'll see if you haven't already seen it. So just this alone gives me, I'm not having palpitations, but in my mind, I can tell that my stress response is going on because I'm like, okay, this is going to take a lot more effort and energy, and a lot more problems can happen. The risk is much higher. I've got to be on my A game. We have to be on our A game all the time with every single patient. And I never take this job lightly. But with someone like this, they can go down, breathing-wise especially, super, super fast. So you've got to have a plan, A, B, and C, and you got to take action, and you have to take it decisively. All right, so what's going on anatomically that makes our world challenging? Oh boy. Large face, large neck. It could be a long neck with lots of stuff, fluff around it, or it can be a short neck, like hardly no neck. Either way, it's very challenging. When I have someone with a large face, large head, lots of adipose tissue, neck, not much neck, I always ask for a second pair of hands. I never induce, I don't push my propofol or etomidate until I have a second pair of anesthesia hands in there. Because I have kind of small hands, and I'm not the strongest person in the world, and they go down, their saturation goes down so quickly, I want to have somebody else there right away. Now, I almost always, not always, but almost always, have an assistive device with me. The McGrath, the CMAC, the glide scope, ready to go. I almost always ramp them. Some places have a rubbery plastic kind of thing that they use. Some people use blankets rolled up. But I almost always ramp them, plus I have them in that reverse Trendelenburg, plus I have the backup. Get them in the position the best you can. Otherwise, what happens is their body kind of folds in around them. They're like this. You're going to try to intubate like that. Even if they had a grade 1 view, you'd never know it. So you've really got to get them in a really nice snipping position the best you can. And then they might be in a pretty good position, and then they're still like this. So I was asking, can you lift up your chin? They do, and I'm like, okay, all right, we can do this. Thick neck. If you see adipose on the outside, the inside's not any different. And you think you know what a normal airway looks like. You do. You can identify the structures. You should be able to. Sometimes when you DL, there's so much adipose tissue in there, you're not sure what you're looking at. Okay, you go in and go, I see the tongue, and you're moving it away. What kind of blade am I using?
You sweep with the
I'm sweeping the tongue. What am I using?
Mac.
All right.
Yeah.
If I'm lifting up the epiglottis,
Miller.
where does the curve go from the Mac blade?
Molecular.
Okay, good. All right. Now we're talking the same. All right. Now you're with me. So I sweep the tongue with my what blade?
Mac.
Okay. And then I'm going to kind of lift up and over, and I'm going to put the blade in that molecular. And then I'm hoping my arm's probably like this, because, you know, bowling ball, 13 pounds, 15 pounds. Or like for me, like the kitty one, 7 pounds. It's not so bad. But so, and a lot of times I will support their head. I'm looking for that. I need the angle, right? What 3 angles am I looking for? The first one, oral, then, laryngeal, then. What? Oh, did we miss one?
OHCL.
Okay. Whoa, remember, this was last semester. Mr. now Dr. Christianberry lecture. So there's, if you don't remember, look them up. 3 things we're trying to get aligned so we can see, we get a grade 1 view, right? So those things have to be in the lung. But anatomically, sometimes people are not in a place that even if you have them in the best position possible, you'll never get a grade 1 view. Okay, but the better experience you get doing direct laryngoscopies, the better your views will get. I have noticed this. I own some. A lot of times they will have limited mobility in their neck. The fat is in the way. They can't move as well. So again, someone that has like a cervical stenosis, you ask them to look at the ceiling and they go, look to the left, look to the right. Their neck didn't move. So sometimes these folks have a similar kind of thing because there's so much tissue there, they don't have a good range of motion. So make a note of that. And also they may have some degenerative joint disease or osteoarthritis going on, like anybody, but especially older as people age, they get this. And because of the weight of their body, they're putting more and more wear and tear on their body sooner. So they're more likely to have wear and tear everywhere. We tend to consider morbidly obese people full stomachs, increased risk for aspiration. A lot of times there's more issues with reflux disease. This will be true with parturients as well. Everybody know what that word means, right? So women that are pregnant, we consider them full stomach aspiration GERD, at risk for that. Same thing with obese people. Now what happens is, what is FRC? I know we reviewed that.
Functional residual
So that's
capacity.
decreased. So what does that mean? Not as much air left over. And so they desat really fast. Respiratory compliance and resistance is an issue. They tend to have obstructive or restrictive?
Restrictive.
I remember the slides, restrictive would be correct.
Yeah.
Okay. There's an increased risk of hypoxemia and atelectasis. So atelectasis, remember when those air sacs, when they collapse? It's just not a good thing. And it happens really quickly. I have seen people be, let's say, 97% SAT, and I like to do this. A lot of people won't take the time to do this. If I have a morbidly obese patient, I'll have their pulse ox on while they're sitting up in the stretcher. But if you're astute enough, you will have this done in pre-op, right? They should have already been on the pulse ox. And you paid attention to what their room air sat was while they were sitting up and comfortable. That's where their norm is. If they didn't do it in pre-op or you didn't take note, before they move over from the stretcher, take just that 30 seconds, hook it up, see what it is, and watch when they go flat. When they go supine, the pulse ox in the ground. So every decrease in pitch is a decrease in saturation. And within 15, 20 seconds. And then we add work to it because they are moving themselves from the stretcher to the bed. It goes quickly. So they could be sitting upright, sat at 97, and decreased at 85 in 15, 20 seconds. Just from the work of moving themselves from the stretcher to the bed. Scary. Now the blood volume increases, but the overall total body decreases. Because there's more tissue, their O2 consumption is greater, their heart's working more, so a lot of times you have cardiomegaly. Something to take note equipment-wise, using the right size cup. Now something I have found challenging with morbidly obese people is that their arm is not typically round and equal. It's more conical in nature. So it's like, it goes like this, so it gets bigger. And so you put a cuff on there, and first of all, it falls off. So then you're measuring their elbow. I don't recommend it. You won't get it accurately. But sometimes you can put it here on the forearm, but that may be where they started the IV, and then you can't put it on this side because maybe they had breast cancer or something like that. So am I going to put it on the leg? You can. Consider the correct size cuff is not my point here. Same thing we do with peds. But in peds, you probably measure it ahead of time and figure it out. With these guys, you have to do the same thing. Where are you going to put it? And it depends on the surgery. If it's a shoulder, right shoulder, everything has to go on the left side. Now you can put a BP cuff on the leg. Some people have very strong opinions about that when they're in the shoulder, typically they're in the sitting position. Do we really want to take a pressure down here when what I'm really worried about is perfusing this stuff? Head, heart, lungs, or kidneys too. So, or then am I going to put everything on one arm, so I have my IV that needs to give them those life-giving drugs and fluids, but every 3 minutes it's going off. So that's interrupting the flow. And also in a shoulder position, your arm's kind of like this. So all the pre-op nurses were helping you out. They got this big 18 gauge right here. And then the positioning would be this arm's out for the surgery, and this one's like this. Anything in the AC, you can test it, bend their arm and see if you still get good free flow from your IV. If you do, fantastic. If not, you have to think about starting another IV. If you don't discover this until after the patient is draped, I hope you're good at pedal IV starts. Because those will be, you'll be able to get those. Things to consider. My main point here is use the correct size BP cuff if you want to get a correct reading. Okay? So if you go to put the cuff on and that Velcro part is not, the cuff doesn't go all the way around, that's too little. If you go to put the cuff on, it wraps around 4 times, the Velcro part barely meets it because that's too big. And you have to consider where you put it, to what size. So you'll get good at this in time. And I know you have some practice in ICU, but it's a little different here because in ICU you can change it in 2 seconds or less. The patients, they're at your mercy and they're exposed to you and whatever you want to do to make the world a better place, right? Anesthesia, they're draped. And you may not have access to where you want to go. You may not be able to get an IV. You may want to find another BP site. It gets stressful. Make sure you have the right size, whether it's the OR bed I mentioned, any other equipment, getting an IV. Sometimes they're easy, but a lot of times they're challenging because we have that extra adipose, that extra subacute fat stuff that makes it really hard to find an IV. So sometimes we'll have to use the ultrasound to find an IV. Sometimes they have those site rights or whatever they call them. Make sure your IV is working before you leave pre-op. Make sure it is. So my habits have been, and I don't know if this is a good habit or not, so you may have to write this down. But my habit is when I push the Versed in pre-op and then flush, I'm testing that IV. If I have any issues or problems, I go, whoops, can't go back. Got to start another IV. Sometimes I'll say, this IV is not working. As soon as we get them in, we'll start another one. Because the OR nurses, if you get them in the room and it takes you 30 minutes to get an IV, it's not on them. They won't get gauged for that. They won't get in trouble for that. If they were supposed to be doing IVs and all that stuff was supposed to be cleaned and checked and it wasn't done, and there's all kinds of politics involved too. My point is, before you induce, you have to have a good IV. You have to know you have a good IV. Once the patient's positioned, you have to double check and make sure you still have a good IV. And it might be more challenging to find it on this person, so it may take a little extra time. So if you have extra time, like we do in anesthesia between cases particularly, make sure you know your IV is working. Once you reposition a patient, sometimes they go from, they have a perfect IV in pre-op, they move themselves over to the bed, and then it's like jammed up, and you have to gently undress and redress it, and make sure it's working. It takes time. You've got to have a good IV before you use it. All right. I like this guy. He did beat anorexia, I am sure. You'll see him later. All right. Cardiovascular, what happens with all this excess adipose tissue, extra body mass? These are the things that are happening. So cardiovascularly, higher risk for all kinds of issues and problems, as well as pulmonary. Those are the 2 big ones. So there's a lot of other ones, but those are the ones, hemodynamics. We've got to keep those right. So there's a tendency to retain CO2, so that's higher, and it's a chronic issue and problem. They're consuming more O2. They tend to get, cardiomegaly, so LVH is a problem. Hypertension at higher risk for CHF, but again, more CO2 produced, and more of it gets retained. So you're going to see higher end-tidal CO2 when you look on the monitor. Pulmonary, hypoxic pulmonary constriction. That's where you're going to see that desaturation. It's just, have you guys seen it? Just even when you're observing in your time, or have you seen really morbidly obese people like desat real fast? And okay, so someone desaturates, and they only can do that for so long, and you're not able to do much about it. What's going to happen cardiovascularly eventually?
ST changes.
Your heart's not going to get the oxygen it needs, and then what happens? Ischemia, and then what happens? And what are you going to see on that monitor? Oh, you're going to see it probably get slower and wider, and then it turns into this nice rhythm to a wider QRS, and it goes into this little flat thing, ACLS now. And it can happen much faster because they're working so hard on their heart's working so hard, they're not getting the oxygen they need, they're more susceptible to having an MI. Just know that going in. Respiratory, we've already really kind of talked about these, but hypercarbia and hypoxia. Oh boy. Why? Airways closed, alexis, a lot more dead space, VQ mismatches going on, shunting. Oh, really, it's making me nervous just thinking about it. So here's what happens in these clinical manifestations, things you're going to see on the monitor. Make sure you make note of this. Pickwickian syndrome. What does OHS stand for?
Obstructive
Hypoventilation syndrome.
What's the O stand for?
Obstructive.
Obstructive hypoventilation. Okay. So we call it Pickwickian. Why? Because Pickwick is the one to figure this out. Even if someone's not diagnosed with obstructive sleep apnea, I usually put presumptive. If you can't lay flat and their spouse that's with them says, oh yeah, they snore, they shake the house, presumptive OSA, even though they're not diagnosed. And then these are the manifestations that go along with pickwickian. I think I have a couple of questions related to that. Just make sure you remember that. What else? The liver, what happens? You're going to have, what do you think happens with these liver function tests? High, low, abnormal? What's that mean? I don't know. You think you're going to be higher?
LFTs go up
Yep.
in 1/3 of patients.
Because it already says right after that, fatty liver, right? Things are going to go up. More likely to have an enlarged liver, which means technically, if they're just going in to have, let's say, a gallbladder removed, more technically difficult for the surgeon as well, because if everything's enlarged, there's not as much space in there for them to work. Problems with the endocrine system. Not only is there fatty tissue in the outside, there's also extra fatty tissue on the inside as well. In the bloodstream, around the tissues, the blood vessels. Obese people tend to be more likely to do have a hiatal hernia, so that's one of those surgeries you're going to see pretty often with them. Hernia repairs, they're going to tend to have reflux problems. They get gallstones more often. Pancreatitis is also an issue. This will be more in our next lecture, but as far as doing bariatric surgery, it's really a great thing when it can make a difference in that person's life. But sometimes it's sort of like, for some folks, a quick fix, and if you don't change your lifestyle and your lifestyle habits and stuff, the problem can still come back even if you have a small tummy. So it's a whole psychological thing that goes along with like bariatric surgery. You have to have lots of good counseling, nutritional counseling, exercise counseling. We're going to hire you for that to take care of these folks, because psychologically, even I've read and talked to folks that psychologically they look in the mirror and see themselves and feel themselves as being this morbidly obese person. So you have to overcome that psychologically. And they probably have a lot of things going on psychologically as they present to you when you're getting ready to do your pre-op assessment. So being kind and considerate and thoughtful and trying to have language that is not offensive. Sometimes it's hard, but you need to remember to be as kind and respectful as you can, because we're there to help those folks. And hopefully this is a step with bariatric surgery that's going to make a big difference in your life and improve the quality of your life. And a lot of these things that show up when someone's morbidly obese will get greatly reduced, and many of them actually kind of go away just with the weight reduction. Again, we're going to see changes in all of these areas. How does that affect them related to drugs and the drugs that you give them? Well, in general, our lipophilic drugs, remember what those are? Okay, so I've got them listed for you. We're going to go by the total body weight for the initial dose. Total body weight. So total body weight includes your ideal body weight. That's just kind of like lean body weight. And then total body weight includes with the fat. And we all have an ideal body weight, and then the extra body weight we have with the adipose tissue that we all have. So initially, higher doses, typically, because we would tend to underdose if we just did it on their ideal body weight. We would tend to underdose. But with water-soluble drugs, and again, samples, you don't want to overdose. So they tend to require lower doses.
Just maintenance dose? Nothing different for
induction?
Mm-hmm.
I usually reduce it a little bit. But the main thing, and you can talk to your CRNAs and see what they do in practice. In practice, I tend to use succinylcholine for morbidly obese people. But some clinical sites, probably Halifax is one, they don't even use sucks. It's like an emergency thing. And there's some clinical sites that won't even use sucks. They've had a bad experience somewhere along the way, they just don't use it. So then you're going to have to use Rocuron or Fecuron. I would probably use for an additional, and I would probably use more for an intubating dose. But then for maintenance, not as much. But you're going to have to, again, technically, you'll just talk with the person you're working with at the clinical site you're working and say, I know that this can be an issue. I don't want to overdose them with the lipophilic drugs, and I don't want to underdose them. I don't want to overdose or underdose for either. So how would you recommend it? Here's my approach. I was thinking about doing this. Would you like me to do anything different? They'll go, oh, that's way too much. Oh, no, that's not enough. Okay, talk it out. Have a plan, though, based on the information you do know. That'll help you out. But when you do a spinal or an epidural, and you're using those local anesthetics, they're lower. So general. Dr. Shores will have plenty of things to probably accentuate and tell you that, and also Dr. Fowler. They will talk to you more about this. But as a general rule, this is an initial guideline. Preoperative, the main thing is the plan. You want to assess everything with every single patient you have. So it's not that different, other than you're going to focus in the areas that you know are especially vulnerable in this population. So they're more susceptible to an MI. You're going to ask every patient if they ever had heart problems. But with these guys, if they've had heart problems, they're probably more likely to have a heart problem. My main thing I want to know, exercise tolerance. That was probably a question on the exam that you had somewhere along the way. Number one predictor, exercise tolerance. If they can't move from their body, from the bed to the stretcher without getting short of breath and desaturating, their exercise tolerance isn't that good. But it might be better than we think if they can walk around when they're upright. They may not get that short of breath. They may be in actually decent shape. I think of some of the NFL people I see on the front line, man, whether it's offense or defense, and those guys are like 320 pounds and 6'5", and they look really obese to me, but I gotta tell you, they're probably as strong and they're probably as fit as anybody. They do have extra adipose tissue, however, which is probably an advantage in their profession. But even still, if I had to take care of them, it could still be a disadvantage. Even, I would guess that their heart and lungs are in better shape than the person that doesn't actively exercise, but they're still at risk for issues. So preoperatively, these are the things to consider. And this really isn't much different than what you learned last semester, but now we're focusing on the obese. So sometimes you're going to see some different issues. When you have them open their mouth, if you see a bunch of redundant tissue in there, expect it to go further down into the airway as when you do your DL. Expect that. Sometimes I have people that are morbidly obese, and it presents kind of like from here down, or just here. And their airway and their neck and their head really are normal proportions. And so you don't see a lot of adipose tissue in their face and their head and their neck. So as far as doing an intubation and doing an airway, slipping in an LMA or an ET tube, it's great. You still probably have to get them in a good position because that body where the mass is can cause issues and problems for you if they're laying down on your flat. But sometimes their obesity is everywhere. Sometimes it's just from the hips down. Sometimes it's just, it starts here and covers to the big toe. So how their body habitus is will help you determine the challenges that you might have. So keep that into consideration too. They might be morbidly obese, but they might have a fantastic grade 1 view and an excellent airway. It does happen. It's awesome. That's usually when I intubate and I go, thank you, God. It went in the first time. Ooh, I didn't mean to say it out loud, but I did mean it in my heart. It's true. The main thing you can do preoperatively is assess like you always would, and then prepare for the worst, considering, do we have the right size bed for the right size patient? How am I going to position them to and from the OR? When you extubate this person, what do you think you'll do? A position. They're going to be upright. And usually they're going to be telling me, I want the tube out. Now they're not really talking to me. But when they start, I said, open your eyes, squeeze my hand, and they're like, okay. I don't like to do those kind of extubations because to me it's just as traumatic for them as it is for me. However, with these folks, because they desat so fast, I need to know that they're awake, they can protect their airway. I'm not going to do a deep extubation on these people. Not going to do it. Be prepared. Intraoperatively, what's going to go on? Our anesthesia technique. Okay. Every obese person I do not do an RSI on, but you know they're higher risk for aspiration, you know they're higher risk for GERD. So some people just do that as their practice. Even the 83-year-old, well, I have 80, I'm saying my 83-year-old, BMI of 83. I was going to say I didn't do an RSI, but I did what I call a modified RSI. So modified, I didn't give them breaths, so I did push the propofol, I pushed the sucks. We just had a little, we had some cricoid pressure, but I really wasn't worried about aspiration because I had them in a good position. I didn't expect that, even though it can happen in any position. But I wanted to see if I could ventilate them. So it wasn't a true RSI, because with a true RSI, we do not ventilate, right? But I wanted to know that I could ventilate this patient. So I pushed the propofol, pushed the sucks, slipped an oral airway in, and then I tried to ventilate. Couldn't do a really good job, so I said, okay, my myologist was there in induction, because again, obese patient, I wanted a second pair of hands. So I said, I'm not pushing the propofol till you get in the room. I get a good mass seal, I do a good jaw thrust. Excellent, easy to ventilate. Thank you. Okay. All right. All these things. The biggest problem I have found is in ventilation based on the position the surgeon needs. If you're doing a laparoscopic case or a robotic case, your airway pressures are probably going to be high. For one, that CO2 insulation. Yeah. Oh, yeah. So sometimes what I'll ask the surgeon, I'll say, can I put this patient in a little reverse Trendelenburg so I can ventilate them better? If it's slight, and then I just adjust the table height to help them, usually they're okay with it. Especially if I have evidence, this patient's desaturating, I'd like to put them in, okay, whatever you need to do. Now, if I did that on every single patient, they're going to go, what's wrong with me? But they usually, they work with you well as long as they can get their job done too. That's why we're there, to get that procedure taken care of. But I want them to end up with a patient that's viable at the end of the surgery. So anytime I think that something's at risk, I let the surgeon know. We usually work together. It's a communication thing. Integumentary issues. Sometimes they're gonna need extra padding. Make sure you protect the skin. Ah, there it is, pedicularis. You gotta figure out how to manage it, because depending on the kind of case, you might have to tape it down, you might have to flip it up, you might have to flip it over. And I don't mean any disrespect, it's a consideration based on what you have to do, so you have to do something with it. Sometimes they'll take those big old wide pieces of tape and they'll do here, and they're just gonna flip it up and get it out of the way so they can do what they need to do, get that procedure taken care of. But I would say the biggest issue for me intraoperatively is oxygenation. That's the biggest thing. If you decide you want, yes.
Oh, sorry. Or when you say consider top line or the second line initial drugs based on ideal body weight, but for the lipophilic, it would be based on total body weight.
Yep.
Or okay.
Yep. And again, I would have that conversation with your CRNA. So for me, I'm probably going to give them more propofol than I would someone with a different BMI. But again, as far as muscle relaxant, for intubation, I'm probably going to give them a normal dose based on this, what I would normally do. But in maintenance, I'm going to give them less. Typically, that's what I'm going to do. You had a question?
Okay.
What else do I want to say about that? Oh,
I have a question that
Okay.
kind of relates to that. So are you going over your 2.5 milligrams per kilogram, or you're just doing the higher end of that range?
That's a great question. For you, I would say go to the highest end of that range, unless you hear different. And for me, it's like big syringe, little syringe, full syringe, half syringe. So, but I would go to the highest end of that. And then if somebody says, the working with says, well, that's not enough, we need to increase it by another half, then I would go with that. That's how I would do it. But, you know, I know big person means, for propofol, it usually means big syringe, the whole thing. I'm going to keep it basic and simple, so that way I don't have to worry about the math involved, I can just do it. But, no, but that's how I would learn. I learned at the high end of the range for that, whereas with the maintenance, muscle relaxant, I would go the lower range. So that way you're memorizing the range. If you know the range, you know, okay, obese people, here I'm going to put them at the low end, here I'm going to go to the high end. Someone may tell you, no, we need to go even half that, or you need to go twice that. Perfectly fine, but you've learned that, you're not learning too much. But just know it's going to be high end or more, or low end and more. And that will help you in your studying consistently. Okay? What are we going to do post-op? The biggest problem they have post-op is related to respirations. Yikes. You want them sitting up, and they before they give the OR, they buy a nasal trumpet from me, free of charge. Part of their overall anesthesia charge is slip it in. Now, a lot of times, people tease me. I will have an oral airway in, so I can ventilate better, and I'll put a nasal trumpet in, so that when you get to PACU and they're like fully awake or whatever, you're like, they're awake enough to spit out their oral airway, they still have an airway in. That's what I do. Some people say, never use tube. I'm like, okay. Then I ask them about their insurance plan. Is your family fully insured? Did you get the cheap stuff? And then they're going to be able to pay 1 month of stuff after you're gone, or did you get the stuff that's going to last them their lifetime? I don't know. I decided to go with the more conservative effort because I have the oral airway, because while they're still not quite fully awake, but they meet criteria to go to PACU, if I need to, I can ventilate them very well with that oral airway, even better than, to me, the nasal trumpet. Nasal trumpet is to help when you get there, and it does help compared to nothing, but I think the oral airway is superior to being able to ventilate someone if you've got an ambient gap or whatever. So I keep it in, I have both of them in, and I'm happy. The PACU nurses are kind of like, why are you wasting all this stuff on the floor? They're alive, they're saturated 98%. Thank you very much, you're welcome. When they spit it out, let them spit it out. The other one's there for your preference. And if it's bothering them, sometimes the oral airways are what's causing people to gag, and you have to decide when to take it out. Okay, take it out. But while they're still kind of groggy before they're with it, and I'm convinced because I wouldn't extubate this person until I was convinced they could protect their own airway. But I don't know how long that's going to last. They could be one cough away from like losing their airway. Trust me, I've seen it. Now, question just came to my own mind, and I don't know the answer. So this would be, I would probably just not too sure, just because his office is close by. So Yamidex, how is it dosed differently? I don't know the answer to the question. Ideal body weight for Yamidex? That's a question I should know. I rarely, I use it a couple times, so I've used it in the Army, but I don't use it in my normal practice.
I would think that it wouldn't matter because it's strength based on your train of thought, not your weight. And if you're getting less neuromuscular blockade, that's what it's attacking. So it's not, and it's
A train of 4 and it's 2, 4, or 16 of course, but it is based on milligrams per kilograms.
But so is that milligram ideal body weight? I think it is,
Ideal body weight.
but I'm not sure. So that's a question that you should get clarified because I don't know the answer to that for Sugammadex. But I do know that if I had it readily available, I would definitely use it for these patients. Boom. Then you can cross that off the list of the problem. Okay? It's not because 70% of the you use neostigmine and robenol and reverse them, and 70% of the receptors are still not doing their thing like, yes.
We, in Tampa, I just did Roux-en-Y's all last week. And we based on total.
Okay.
Yeah, I mean, they also had 2 out of 4 on the train of 4. So, I mean, it was like 2 to 4
Okay.
milligrams per kilogram.
And it might be a question too that what you learn in class for your exam, because what the books say and what people are finding works best in practice, I hate to say, could be somewhat different. So when you're getting your lecture and the reading and it says ideal, we go with that. And when you're in clinical and they say we base it on total body weight, do that. I'm not going to say one's right or wrong. I'm just saying you may have more than one answer to the same question. So know for study purposes what's going to work for your studying and passing that exam. And when you get to the clinical site, they may have some other ways of doing it. It's their preferred technique at that site, and that's what you do. I did a Roux-en-Y yesterday too, and I was able to do it so wonderfully without irritating my surgeon. So I used succinylcholine. This person only had a BMI like 50 though, so it wasn't extreme. But I used succinylcholine, and then once she came back from that, then I only gave like 25 of rock, and I only redosed once with 10 milligrams of rock. That's all I needed. By the end of the case, 4 full twitches. I did a minimal reversal. I used neostigmine and robenol, and had no problems at all. But she was right on that edge, like, should I redose again? Because I'm like, because you're watching end-tidal CO2, and when you see it, maybe slightly rebreathing, they're not quite done. They want them fully relaxed the whole time, and then we're done. Okay, so if you just redose, you're like, this won't be well. Yeah, because usually, even a small dose, they'll get, sometimes they'll go down to 1 twitch, but a lot of times they'll go to 0. And then you're like, okay, and now we have another 5 cases to go to these and take care of it. So Gamadex is awesome for that. So you have an opportunity to use it. I think you use it all the time at Halifax, right? Yes, no?
Yeah.
So Gamadex? No?
They told me it was too expensive.
Yeah, they
Well, that's kind of like what our site says.
Yeah,
too.
I thought so too.
They use neostigmine.
Mm-hmm.
Do they? Oh, maybe it's
It's Mayo.
Flagler uses
TGH.
Mayo
right?
uses
Flagler does, Mayo does, Baptist,
Mayo.
TGA. Awesome. It's good for you to be able to do both. Yes.
In that scenario where you're on the threshold not knowing if you're going to need to reparalyze them or what, so if the surgeon had said he needs them or she needs them more relaxed, could you maybe just deepen your anesthetic?
You can
Use
turn up the
nitrous
gas. You can turn up the gas. You can use nitrous. You can do a bolus of propofol. Oh, did that help? Oh, yes. Thank you so much. Thank you. Perfect. Yes. But then again, it's based on the hemodynamics. If they've been hypotensive the whole case and you don't really want to give them 100 milligrams of propofol or increase the gas because you know they're going to dilate, it's going to drop even more. Sometimes I will do that for the surgeon to get him relaxed, and I will use increase in gas, increase in propofol, and I chase it with either phenylephrine or ephedrine based on their heart rate. So, and sometimes I've made decisions where I used 10 or 15 of rock and it was too much. And I just had to, say, I'm sorry, beg forgiveness. And again, as long as I'm not doing that with every case all the time, they forgive me. All right, post-operatively, the biggest thing is going to be management of the airway and how you did the case. Are we doing this? These are perfect ERAS cases when you can do them, or TIVA cases if you can do them. This would be a good case with Dr. McDonough. I think you could learn a lot. The one I did was a Roux-en-Y, and we did a lidocaine drip. I had it at 1 milligram a minute and during the case, and then about in the last maybe 20 minutes I had it turned off. So they're not so comfortable that they won't wake up. And they usually don't wake up like the normal sense of waking up because they're just so comfortable. But it was a good case because I used 100 of fentanyl on induction. Now I probably didn't need to do that. I probably could have doubled just my lidocaine dose. Now what happens sometimes, and it depends on your facility, if they continue on the lidocaine drip past PACU into the floor, then that's great. They might lower the dose to 0.5 milligrams a minute on the floor. And they can do that and supplement with other things. So they're usually given either a formative liquid or they're giving Tylenol suppositories. They might have been given gabapentin. They might have Toradol regime. Some places use magnesium. But I've got to tell you, my patients, when I left them in PACU and then checked on them later, they were really pretty comfortable. But what happens if we just stop the lidocaine drip 45 minutes or so after that, they wake up in excruciating pain because the lidocaine wasn't continuing and we didn't give them enough narcotic. Problem with these folks, if you give so much narcotic, they're not going to breathe. And we know we already have respiratory problems. So if you over-narcotize these patients, it can be a real serious problem in PACU for PACU people. Because by then, you may leave them in pretty good shape, and then they decide they're in pain, and then they might overdose them pretty easily. And then they have problems related to that. So it may not be your anesthetic itself, it may be in combination. These are really good cases to do with the ERAS protocol, or we'll see with the bariatric, what they use it, Flago, their basic thing. But you want to use everything you can to manage their pain, and we like it to be opioid sparing if we can. Some places that's not an option. But when it is, these are really good candidates for that kind of case. All right. Induction, prepare for difficult mask. Oh, and if they have a beard, even harder. Our mask, the adult masks, really, there's one size, right? There's lots of pediatric sizes. The adult, it's like one size. So if someone has a big nose, it covers their nose and hardly their mouth. Or if they're a little petite person, this would not usually be a morbidly obese person. But if they have a tiny little mouth, that mask is like covering up their eyeballs and it goes down here on their chin. So sometimes it's really hard to get a good seal with the mask. You get the mask, whatever it is. And they tend to be difficult to mask for that extra tissue, the size of if they happen to have a big head and big mouth, it's really hard with that mask, or a big nose, it's really hard to get a good seal. So things to consider, you may want an extra pair of hands. And the OR nurses that work with me regularly, I'll say, okay, and I already think about it ahead of time. The BMI and the next patient is whatever. I said, I'm going to probably want your help to ventilate that patient. I go, okay. So I hold the mask and I have them do I turn on the APL valve when I want it, and then squeeze back in. They want to go, they go, no, let's slow down. You take a breath. Okay, now breathe. And I tell them to just walk through it. Okay, good. Because I need both of my hands here. Now, when I'm with a student, it's awesome. So sometimes they'll be struggling with a bigger faced person and masking, and they'll try, and I'll do the bag, and I go, okay, let me try just to see where we're at. So I try, and I'm like, okay, we're good. So you can do this. Let's talk about your technique and get it down so that they try, and they go, okay, see, that's all you have to do. Usually it's related to jaw thrust. And the finesse of getting the mask, where it doesn't have to be down hard, it just has to be sealed. so covered. So you may have a bunch of it coming out, you know, I'm losing it. So sometimes if someone just does this to the cheek and lifts up against the mask, that's all you need. One person just do that. Okay. Sometimes it's related to getting a jaw thrust. If you ever have problems ventilating, I don't waste any time. I do one, not more than 2 breaths, and I slip the whole airway. I don't mess with it. I just slip it in. No, okay, now I'm good. Make sure you use the right size roll airway too. We know we have the measurements for them. Sometimes they're accurate, sometimes they're not. It's the best measurement we have. You do the best you can. But if you have one that's sticking out of the mouth like this much, it's too big. So get the next size smaller. Just because there's a guy doesn't mean they get the biggest one. I think the size 10 or it's ours, it's a red one. So I think that 10, 9, 8 is the normal. Those are the normal adult size. So if you see that it's not fitting well, part of it might be you and your placement. So do a little jaw thrust, and if it falls right into place, it's like, oh, it's not the size of that. It's your technique and just more practice. But make sure you follow these basic guidelines. You know you're going to desaturate quickly. Alveoli squeeze in real quick. They just don't have much, what is it?
FRC.
FRC, that's correct. So denitrogenation is going to be a #1 thing for these guys. And it may even take a little extra long compared to your normal induction. Make sure they have good saturation before you go to sleep. Sometimes people will not get any higher than 97. That's as good as they're going to get. Okay, well, don't wait for 100 because you'll be waiting all day. But get it the best you feel like you can do before you go to sleep. Now, I would consider, what is FOI?
Fiber optic.
Fiber optic intubation. I can't even remember last time I did one. And also a surgical airway. These would be emergency cases when you can't ventilate and you can't intubate. Now, I would say that morbidly obese patients are at higher risk for that, but I've been doing this a long time, and I have never had to do a surgical airway on morbidly obese patients. And rarely, and I mean 2 or 3 times in 10 years, did we have to consider an awake fiber optic. I'm not saying don't consider it. I'm just saying in practice, I rarely have had to do that. Even with big folks, I usually don't. But you need to have that in your toolbox and be ready and prepared for it mentally, because you may have to consider this. All right, for maintenance, sometimes you might have to put them on more than 50%. Typically, you put patients on 50%. If I don't do, sometimes it might be higher. Do whatever you need to do to get the saturation you need. All right? Their end-tidal CO2 is going to tend to be higher, so you might have to increase the respiratory rate to kind of help them blow it off. But know that they naturally retain it, and it's going to be high. Careful position, we've mentioned, it's super important. When you emerge them, make sure they're completely reversed and fully awake. In what position? Sitting up. Yes. All right. Problems. The main thing is that you plan for potential problems, right? And you're looking for them. EKG, you know they're at high risk for MI, so you're going to be looking for that. What are we looking for? ST elevation or depression. Depression would be ischemia, so usually ischemia can lead to. So watch your EKG. Plan for positioning and what you might have to remember before you induce. Maybe a little reverse Trendelenburg, back up a little bit. Ramp the shoulders, get them in a good sniffing position, and see if that place that you're working has a special ramp, or you have to make your own, or how they handle that. Expect the fact that they're high risk for cardiac and respiratory problems, and make sure you know the ACLS protocols for MI, and what are you going to do for respiratory arrest. Make sure you kind of have a plan. Don't forget about that. They'll be intubated probably already because of the procedure. Now, we don't intubate every single morbidly obese patient, depending on what they're having done, but expect they're probably going to already be intubated. If not, you're probably going to have to intubate them. The main thing is to be looking for it, thinking about it, know they're higher risk, and be prepared for it. All of these things related to hearts and lungs, especially, That's going to be your main area of concern, and they're high risk for aspiration. Then when you drop them off in PACU, you want to leave them in a position that you've helped that PACU nurse have them as optimized as they can be. So you want to control their pain and manage their pain. Think of alternative methods to keep them comfortable, and we don't want to over-narcotize them. But they still have, their pain is as real as anybody else's pain, so you got to manage that. You got to figure out a plan. So you may want to have a plan A and B the night before. If you call your CRNA with a plan, talk about plan A and B. That morning when you meet your CRNA and say, here, you've got this gastric sleeve we're going to do today. How are we going to manage that? Here are some options, or here are the plans I was thinking about. Talk with them and see how they typically do it. Because we all have our own opinions about things, and we know the surgeons we work with, and different surgeons want different kinds of things, and different clinical sites want different kinds of things. I wish we used the protocol at St. Vincent's that they use at Flagler. I wish we did. We don't. So I have to do it the way it's expected in my facility, that I can manage it. I can use ketamine, as long as I'm not, everybody that I work with is not waking up hallucinating. If I manage it to supplement their pain management so I can be opioid sparing, plus I've done Toradol, I've done lidocaine boluses maybe in the case, if the surgeon doesn't want me to do a lidocaine drip. So I'm going to do what I can to manage this patient the best I can based on my experience and what the surgeon wants and what the anesthesiologist I'm working with, the plan we come up with together. All right. I like it. Obesity is here to stay. Assess your patient well, but you've got to be able to do that really well, be very accurate within a 3 to 5 minute period of time when you see that patient, right? You know it's faster than you want. You want more time. You won't have it. Anything you do the night before, great. If you just have to show up that morning and wing it, you got to do the best you can, decide what the priorities are, and know that. Be able to give a report right away. So, if you have any questions about labs or EKGs if you're there, chest X-rays, sometimes it may be there, it may not be there. But you can ask the questions. Once you're standing those questions, ask the anesthesiologist working with your concerns. You've got to figure those out pretty quickly, though, based on how the patient presents. Remember this? Mr. Ingber's famous quote, it is always true. Be prepared, plan A, plan B, plan C. Know they're going to be a challenge, but you will learn to handle it. And the more you take care of folks that are extremely big, the better you'll get and the more confident you'll feel in being able to take care of them safely. But know this, they're at higher risk. So I never, ever let that leave my mind. When I set up in the morning, I do this for every patient, but when I set up in the morning, especially these folks, the first thing I set up, my emergency drugs. This is my everyday. Emergency drugs, I set those up first because I never want to forget that what I do is super dangerous. People's lives are in my hands every second of every day. So I always set it up with my emergency drugs first. Then I do my airway stuff because I'm considered the expert. Then I get all my routine stuff done. Most of the cases, everything goes fantastic. And you've seen it. You know, you see more great outcomes than you see problems. Probably. Right? I mean, in your experience so far, right? You see, go to sleep, they wake up, everything's full. This is awesome. And then you get folks where they have lots of comorbidities and things are very difficult to manage, and sometimes they don't do well, and then you have to respond to basically literally save their lives, save their life through that surgery, and you hope it works out. Sometimes you're going to get patients that are already at the brink of death because of a level 1 trauma, is typically what I'm thinking of, car accident, multiple gunshot wounds, some type of serious problem. They come to you, they're circling the drain of death because they've lost so much blood, and it's going to be your job to try to resuscitate them and bring them back. Sometimes it works, where you are able to save them, and sometimes you don't. But you want it to be where you're doing everything you can to give them the best advantage of keeping them alive and saving their life, not be the one that caused their demise. That's the biggest fear I probably have in anesthesia, is doing the wrong thing, giving the wrong drug, or not giving the right drug when I need to. You get really good at it, so I'm sure you're not going to have that problem, but never let that leave your heart and your head that it's your responsibility that you keep that patient alive. You watch every breath and every heartbeat to get that patient through that safely. It becomes more challenging the bigger they are. All right, quick break.